Welcome to Pathology Central Key Concepts. The topic of this video is acute and chronic liver failure. You'll be learning about many diseases that cause acute and chronic liver failure. This video will focus on how to make the diagnosis and what the impact will be on the patient. With that in mind, I will begin by reviewing the laboratory evaluation of liver disease, and next discuss the etiology, clinical presentation, laboratory values, and morphologic findings in acute and chronic liver failure, finishing up with a description of the clinical consequences of chronic liver failure. So, how do you make a diagnosis of liver disease? So perhaps your patient presents to you with jaundice or icterus, which raises your suspicion that there is some sort of hepatobiliary disease, or perhaps this is something that you pick up on a routine screening test. In order to get a better idea of what is occurring in the liver, there are a variety of laboratory tests that we commonly order. I've put the most commonly used tests here in boldface. Furthermore, I have categorized these based on what these tests are trying to assess. So for example, if we are interested in determining whether or not the hepatocytes are viable and not necrotic, so what is their integrity, we're going to look to see if any of their cytosolic enzymes have been released into the blood. This is a similar principle to looking at troponin levels in a patient in whom you suspect a myocardial infarction. The cytosolic enzymes that we look for in liver disease are serum aspartate aminotransferase, serum alanine aminotransferase, and serum lactate dehydrogenase. And we will refer to these often as just AST and ALT. Another question that we can have when we're assessing the possibility of liver disease is, how is the biliary excretory function? So we have two ways of assessing this. The first is to look for levels of substances that are normally secreted in bile. When we have liver disease or liver damage, we would expect these levels to increase. So we can see here that the most commonly ordered test will be serum bilirubin, both total and direct. Now, another test that can be done, which is less common, is urine bilirubin. However, this is an easy to perform test in the clinic. It's a simple dipstick and may be the first indication that additional tests are necessary. In addition, we can test for serum bile acids. And when we look at biliary excretory function, another way we can measure this is to look at plasma membrane proteins, because they will tell us if there's been damage to the canaliculus. So there are two plasma membrane proteins that are found on the apical tip of the hepatocytes where they form the canalicular membrane. And this will be alkaline phosphatase and gamma-glutamyl transpeptidase, or GGT. Before I go on to the last category, I just want to remind you that when we order these tests, we typically will order them as a panel. So a serum alkaline phosphatase on its own will not be tremendously informative, but if you combine it with your aminotransferases as well as your bilirubin and GGT, that can give you a good image of what is going on in the liver. And the third category that we would be assessing would be hepatocyte synthetic function. So as you're aware, the liver makes abundant proteins that are necessary for life. One of the ones that we will measure will be serum albumin. When we have extensive liver disease, serum albumin tends to fall. The liver is as well involved in generating coagulation factors, and we don't tend to assess these individually. We don't look for, factor 10 or factor 12, but what we assess is the actual clotting of the blood. So we'll look at a prothrombin time or partial thromboplastin time, because that actually answers our question that we really want to know: does this patient have appropriate hemostasis? Then the final way that we can assess hepatocyte synthetic function is to look at hepatocyte metabolism. One role of hepatocytes is to metabolize ammonia to the non-toxic urea. So when we see that serum ammonia is rising, that can indicate that our hepatocytes are ailing. So I'm going to begin now with acute liver failure, which is defined as acute liver illness that produces hepatic encephalopathy within 6 months of initial diagnosis. And I'll tell you more about hepatic encephalopathy in a moment. There are multiple causes for acute liver failure in the United States. Acetaminophen excess, either intentional or accidental, accounts for about 50% of cases. Other causes that are common in the United States include autoimmune hepatitis, acute hepatitis A and B, as well as drugs and toxins. In Asia, by contrast, we see that the most common cause of acute liver failure will be hepatitis B and E. The presentation of acute liver failure can be somewhat nonspecific with nausea, vomiting, and fatigue. However, jaundice is an indication that the liver is being damaged. With progression, we will get encephalopathy, coagulation defects, and portal hypertension. The laboratory tests that you'll be using to evaluate your patient will be your transaminases, so ALT and AST, which will be markedly elevated in acute liver failure. This is because in acute liver failure, we have massive liver necrosis, which is going to release all those cytosolic enzymes into the blood. Over time, however, as we get increasing destruction of the liver parenchyma, there will be fewer hepatocytes to generate these cytosolic enzymes, so we can see our ASTs and ALTs trending downward. And though you might interpret this as the patient improving, it may not be an indication that that is the case. Other laboratory tests that are elevated in acute liver failure are bilirubin, alkaline phosphatase, and lactate dehydrogenase. Now, the initial presentation of acute liver failure, the liver will be very enlarged, and this is due to hepatocyte swelling, edema, inflammation. As you recall, when we have necrosis, that's going to bring in a lot of inflammatory cells as well as edema. But over time, we're going to get this resolution into a small and shrunken liver due to the loss of parenchyma. And what we will see histologically will be massive liver necrosis with broad regions of parenchymal loss. This is a biopsy from a patient with autoimmune hepatitis. And I think you can immediately appreciate a few things. One is that the hepatocytes are just markedly enlarged and reactive. The reason they look so reactive is because they're basically in this soup of cytokines that is being released by all of these inflammatory cells. And you can see here that we've lost the liver parenchyma entirely. So about a quarter of this biopsy field is necrotic. When we look at another field from the same patient, you can see there are barely any viable hepatocytes. We have a few bile ducts here, but mostly inflammatory cells and hepatocyte collapse. And in this patient, about 50% of the liver was necrotic. So how does acute liver failure manifest? We talked a little bit about some of the signs and symptoms, but let's look with a little bit more detail about what can develop. So with our liver failure and the decrease in bile flow, we will get jaundice and icterus. And then we can get hepatic encephalopathy due to increasing ammonia levels, and this can manifest initially as confusion with progression to stupor, coma, and death. As I mentioned before, the liver will metabolize ammonia to urea, and without this function, we're going to get a buildup of ammonia in the blood, which can affect the brain. There's another finding that we can see called asterixis. This is a non-rhythmic rapid extension flexion movement of the extremities, and this is commonly elicited by having the patient put their arms outstretched with their hands dorsiflected, and then they will tend to beat non-rhythmically like this. With acute liver failure, we can get coagulopathy, which can manifest as a bleeding diathesis because, as you're well aware, the liver makes coagulation factors, and when it is failing and we have massive necrosis, there will be a decreased production of coagulation factors. However, on the other hand, we can present with clotting, with disseminated intravascular coagulation, because one of the liver's roles as well is to clear coagulation factors from the blood. So we have decreased clearance, so there's a balance here between bleeding and clotting. Portal hypertension is something we'll talk about more when we talk about chronic liver failure, because that's where it's more common. But you can see this in acute liver failure due to obstruction that is either pre, intra, or post-hepatic. And this will lead to ascites and contribute to encephalopathy. And then there's one more consideration, which is hepatorenal syndrome, which is a little bit complicated, so let's give it its own slide. So hepatorenal syndrome is defined as renal failure when you're in the context of acute or chronic liver failure without any intrinsic renal pathology. So how does this occur? As the liver is failing, we're going to get the release of vasodilators, which will increase blood flow to the abdominal viscera and decrease perfusion of the kidney. When we get decreased renal perfusion, we're going to get a decreased glomerular filtration rate, which is going to drive activation of the renin-angiotensin axis and the renal sympathetic nervous system. This is going to result in vasoconstriction of the afferent arterioles, which is going to cycle back with decreased renal perfusion pressure, which is going to take us back through this loop. And with this decreased renal perfusion pressure, we're going to get decreased urine output, increased blood urea nitrogen, and increased creatinine levels and renal failure. So how do we treat patients with acute liver failure? The most important consideration will be to treat the underlying cause. So for example, if a patient has widespread necrosis due to autoimmune hepatitis, you treat with immunosuppression. If you cannot treat the underlying cause and there is progressive disease, this can lead to multi-organ failure and death unless the patient can get a liver transplant. So this brings us to the second category, which is chronic liver failure, which has some overlap with acute liver failure, but some unique features as well. Now, we define chronic liver failure most commonly as cirrhosis, which is going to be a diffuse transformation of the liver into regenerative nodules surrounded by fibrous bands. However, not all chronic liver diseases will progress to cirrhosis. So for example, primary biliary cholangitis and primary sclerosing cholangitis do not always progress to cirrhosis. And furthermore, not all cirrhosis leads to end-stage liver disease, which is to say coagulopathy, encephalopathy, etc. So one example of this is that you can see cirrhosis in autoimmune hepatitis, but still be spared end-stage liver disease. The etiology in the United States is most commonly going to be chronic hepatitis B or C infection, non-alcoholic fatty liver disease, and alcohol-related liver disease. And one more important fact to know about cirrhosis is that cirrhosis can regress with the appropriate treatment. So both grossly and microscopically, we're going to see regenerative nodules separated by fibrous bands. And grossly, this is going to appear as a nodular surface. So let's go ahead and take a look at that. Here you can see a gross specimen of liver, which has this very nodular and bumpy surface. You can also appreciate that this liver is quite small. That's one of the findings in cirrhosis, is that the liver tends to contract with these fibrous bands and become small and shrunken. Here's a higher power view of the surface where you can appreciate this nodular appearance, as well as a slight greenish tint from cholestasis. And then here is a section of cirrhotic liver where you can confirm that the nodules are not restricted simply to the surface, but in fact the entire liver is replaced by these nodules. Now, what can we see histologically? Here you can see in a patient with active excess alcohol consumption for a long duration, this is the appearance of cirrhosis. So we have these nodules of hepatocytes that are regenerating, separated by these fibrous bands. This is a trichrome stain in which collagen is stained blue. But as I mentioned, cirrhosis can, in fact, regress. Here's that same patient following long-term abstinence, where you can see much of the fibrosis has resolved and the liver is looking much healthier. So how does chronic liver failure manifest? Well, we have some similarities with acute liver failure, such as jaundice and icterus, encephalopathy and coagulopathy, but there are some other findings that occur because of its longer duration. So with long-standing cholestasis, patients may present with really intense pruritus, thought to be due to the deposition of bile salts in the skin. There's impaired estrogen metabolism by the liver, which can lead to palmar erythema due to local vasodilation and spider angiomas of skin. In males, this excess estrogen can lead to hypogonadism and gynecomastia. There can be disruption of the hypothalamic pituitary axis due to either nutritional deficiencies or hormone alterations that can lead to hypogonadism in females. And then we're going to focus a bit of time on portal hypertension, because when I showed you that image of the section of liver and you saw those nodules, think of the difficulty of blood to flow through that very nodular scarred surface. And this is going to increase the blood pressure in the liver, which is going to have a number of effects. So what causes this portal hypertension? Well, we have increased vascular resistance due to the contraction of vascular smooth muscle cells and myofibroblasts in this injured, scarred liver, and the scarring itself will disrupt blood flow. In addition to having increased vascular resistance, we have a second hit, which is that we have increased portal blood flow. And this occurs because in chronic liver failure, we're going to get arterial vasodilation, primarily in the splanchnic circulation. It's thought to be due to nitric oxide, or NO. And this is going to increase blood flow into the liver. So there are some consequences to portal hypertension. The first one I'd like to address is ascites. So ascites is defined as the accumulation of fluid in the peritoneal cavity, and about 85% of patients who do have ascites have it secondary to cirrhosis. This fluid is a serous fluid with less than 3 grams per deciliter of protein, mostly albumin, and will become clinically apparent when it's over 500 milliliters. And this will be part of your physical exam when you check for a fluid wave. So what causes ascites in portal hypertension? I'm going to go into a little bit more detail than is covered in Robbins just to provide some more understanding. So as I mentioned, in chronic liver failure, we're going to have arterial vasodilation due to, as I mentioned, various mediators, mostly nitric oxide. And this is going to take us down through the renin-angiotensin axis again, leading to the retention of water and sodium. So we're increasing our body fluid. We will also be activating our endogenous vasoconstrictors, which are going to increase pressure. So remember that when we look at the flow of fluid in the body, what determines its flow will be pressure, and which can be based on volume, or oncotic pressure, which is based on proteins. So we've increased our pressure here, and we've increased our volume. We're actually going to decrease our oncotic pressure because the failing liver will not be making albumin, which is critical for maintaining oncotic pressure in the blood vessels. And we will also have a hyperdynamic circulation, which occurs in chronic liver failure as we get this arterial vasodilation and feedback. This is again going to increase our portal venous pressure. So this decrease in oncotic pressure, increase in our intravascular pressure is going to push fluid out. Another finding that we can see in portal hypertension is portosystemic shunts. This is when we have this very high pressure in the liver. We're going to have vascular dilation and remodeling to create venous shunts between the portal and systemic circulation. These are the principal sites. I'll start with the most important for your patient's health. These are the portosystemic shunts at the esophagogastric junction. This can result in massive dilation of the esophageal veins, referred to as esophageal varices, which we see in about 40% of patients with cirrhosis. These veins are very dilated and thin-walled. They're just below the surface of the mucosa, and they can rupture, causing massive hematemesis and death in 50% of patients with esophageal varices. And in fact, each bleeding episode carries a 30% mortality risk. We can also get shunts at the rectum, which yields hemorrhoids, in the retroperitoneum, and in the falciform ligament of the liver. This results in periumbilical and abdominal wall collaterals that are referred to as caput medusae because of the appearance of these veins snaking out from the umbilicus. And I'll show you an image of that in a moment. So this is looking at esophageal varices. This is a contrast study. These are very rarely done nowadays, but you can see here how massively dilated the vessels are in the esophagus. Now this is from that same patient. There was ligation of these varices, and you can see here that this is where one of the varices is still bulging out into the lumen, very thin-walled, which you can appreciate here on histology. Here's the mucosa, here's this dilated vessel. Any sort of trauma can cause a rupture here and massive hematemesis. Here is an example of caput medusae. This is a very dramatic example where you can see this massive dilation of our abdominal wall collaterals radiating out from the umbilicus. The final component of portal hypertension I'd like to mention is splenomegaly, because we are going to get back pressure of blood to the spleen, which is going to result in congestive splenomegaly. The spleen is going to enlarge. Now, one of the roles of the spleen, as you're aware, is to clear out damaged blood cells and platelets. And when you have an enlarged spleen, you have a greater surface area. You can get sequestration of these blood elements that can lead to hematologic abnormalities such as thrombocytopenia and pancytopenia. Now, this thrombocytopenia is additionally a risk because remember, your patient is already perhaps has a coagulopathy. So let's put all this together in a figure. This is from Robbins and Kumar, Basic Pathology, and I've color-coded it so you can see that in green we have the findings that are associated with excess estrogen, such as spider angiomas, oligomenorrhea, amenorrhea, and sterility, as well as testicular atrophy. In red, what is associated with portal hypertension, so our esophageal varices, our splenomegaly, our periumbilical caput medusae, hemorrhoids, and because of the increased pressure, that's going to contribute to ascites. And then with our decreased liver function, we'll be implicated in ascites as well because of the decreased amount of albumin, as well as in our hepatic encephalopathy. Our decreased liver function will also contribute to a coagulopathy. And then when we have cirrhosis, that is one of the risk factors for hepatocellular carcinoma, which we'll talk about in a moment. So let's review the clinical features of chronic liver failure. About 40% of patients are asymptomatic until the disease is very advanced, and when they do present, it may be with nonspecific manifestations such as anorexia, weight loss, or weakness. The most common cause of death for patients who are unable to obtain a liver transplant will be hepatic encephalopathy, bleeding from esophageal varices, and hepatocellular carcinoma. Now, I've referred to hepatocellular carcinoma twice. Let's take a brief detour just to talk about it in the context of chronic liver failure. So about 80 to 85% of hepatocellular carcinomas arise in cirrhotic livers, so in end-stage liver disease. The most common underlying diseases of this cirrhosis will be chronic viral hepatitis B and C, metabolic diseases such as hereditary hemochromatosis or alpha-1 hemotrypsin deficiency, alcohol and non-alcohol related liver disease. And let's just take a look at a hepatocellular carcinoma arising in a cirrhotic liver. You can see here the nodules separated by fibrous bands. That is sort of characteristic of cirrhosis. But then we see this larger nodule here. And it has a variation in its appearance, a more yellowish appearance here. And what we can see on biopsy is that this nodule is in fact a well-differentiated hepatocellular carcinoma. Okay, as always, here are some questions for you to test the material that you've just reviewed. I hope you have found this video useful. Please do subscribe to my channel. I really do appreciate it. Thank you.